So if we can get the speakers for the panel section right now to take a seat in the front. And I would say, everyone check your wallets. We have an extra one. It's downstairs if you don't have your wallet. Mrs. Zamudio has it, so. I'll start with a quick question then. Neeru, I don't know if this is misuse of your research, but in the past, I've known this body of work, and to me, it meant that neuroregeneration is not possible from the optic nerve.
So I might have skipped over because I was conscious of the timer. But, there's a huge opportunity for us to take advantage of this because now we can go looking for that thing that is inhibiting axon regrowth. Just it's not very different from the VEGF story, right? You find that thing that is stopping it, and there's tremendous hope actually for regeneration. And there's a lot of work that I couldn't cover here in terms of regenerating axons, getting things to grow back, make new connections. And so that's an exciting area going forward.
It is well known that in refractive or strabismic amblyopia, similar changes happen in the occipital cortex. Is there a correlation between the changes between the two conditions?
So in very early studies, way back, if you monocularly cover one eye and you make the monkeys amblyopic, you can induce some changes in the brain. Those changes haven't been studied extensively enough to understand whether that's input. These changes are input related, or there's actually a death. And so, yes, there are some conditions where, even macular degeneration and things where there is suspected changes in the brain, but the mechanisms are less understood.
Joe, not every species has a lamina. I mean, why do we have a lamina? It's almost like, we're only finding problems there. I mean, what was the original purpose?
Yeah, I think it's to protect acuity and to protect survival. So, rats have laminas. It's more of a cellular lamina. It's not a mechanical lamina per se, but it's a lamina, and it's a cellular lamina, and those cells provide the same sort of function. But rats, for instance, don't have the acuity that we have. They have better peripheral vision, but not central vision. So I think it has something to do with evolution, survival, and the role of vision in our survival as humans. I mean, that's a big picture answer with that.
It's a tough question. I mean,
real answer is I don't know.
In the measurement of the lateral geniculate with MRI, are the MRIs done without contrast or with and without gadolinium contrast?
No, these are without contrast.
The MRI-related changes that are seen in glaucoma patients. I was wondering if childhood glaucoma patients have had their lateral geniculate height checked to see if there are also changes in. Is there anything done on childhood glaucomas measuring the lateral geniculate height in childhood glaucoma patients? I'm just wondering if any such data out there.
Oh, well, that's a very interesting question. It would be interesting to see what's happening. I don't know. I don't think those studies have been done.
When comparing the laser, the SLT, and the micropulse, I'm wondering if you can suggest a difference in the mechanism. The size of the laser spots seem to be the same. It's relatively contiguous. Hopefully neither is really doing damage. I don't know if the micropulse is applying multiple pulses to each spot and the SLT is just one, but can you suggest some difference in the mechanism, why one might have a different clinical effect than the other, or be more desirable than the other?
So I think that, honestly, I have no idea. So the micropulse would still target the pigmented
cells in the pigmented trabecular meshwork, but I'm not sure why.
So the micropulse mechanism is really a mess, and it was really, I mean, if you can think about it, it's an adaptation and a progression from CBC, which is obviously cyclodestruction. And really, when we do micropulse, we're billing it as cyclodestruction. But the probe is different where it aims, and so theoretically, it could have a different mechanism. And there's suggestions that almost like multiple pathways can be hit. You can think of it as destruction in the first place to turn the faucet down. As Alex mentioned, Murray had data up in AGS where basically he felt that it was contracting the longitudinal ciliary muscle to pull down on the skeletal spur, and then his conventional outflow. And then Paul Chu, who was the inventor in Singapore, is adamant that this is uveoscleral. I just met Paul in the UK a couple of months ago, and part of his rationale, and I've seen this too clinically, is that when you micropulse, you don't always get an IOP reduction right away. Sometimes it could take a little bit of time, kind of like a prostaglandin. And so the thing that actually hasn't been done that is that classic aqueous humor dynamic parameter analysis that, let's just say, like cytoskeletal relaxing agents, they're getting that tested now. Phacoemulsification, as Dr. Chopra said, is getting that tested now, but it hasn't been done in micropulse laser.
Dr. Gupta, in your patient who died and have 0.9 cupped disc, the visual field was not typical of advanced glaucoma. The visual field was by superior hemianopsia. This is typical for ischemic brain disease and not for advanced glaucoma.
Thank you. Actually, the patient's visual field was quite typical of glaucoma that I see, and in fact, the MRI study that we performed in the selection of patients, we chose patients who had very similar field change. It was not difficult to find that in glaucoma practice, and so these are advanced changes. It's not uncommon to see split fixation.
Dr. Chopra, I think it's pretty clear now, especially with all those MIGS clinical trials, that cataract surgery alone lowers IOP. There's just no question anymore. But I don't know if anyone in the audience yourself has gotten to the point where you can actually look a patient in the eye and say, you know what, you've got glaucoma, your pressure's too high, and I'm just going to do cataract surgery alone without any discussion of anything else. Is that a culture issue? Is that a regulatory issue? Or is that something that actually is coming?
Yeah, cataract surgery alone likely is not going to be sufficient as the only procedure for that patient. But again, if you look at the patient as I showed you in that chart, and if they have a well-controlled pressure, the cataract is developing, you may get that additional benefit from cataract surgery. But I don't think cataract surgery is going to be used as the primary procedure for glaucoma, even if the glaucoma is relatively mild. It wouldn't be your go-to procedure, but it definitely plays a significant role. Again, the other thing you mentioned is, if the patient's vision is quite good, sometimes it's hard to justify cataract surgery. There are risks to cataract surgery, even though, we talked about capsular complications. There's other risks that we didn't really touch base on. I think pseudophakia, simply makes the future procedures a bit easier, as shown in Joe's study. I don't know if Joe has anything else.
So, Alex, I hope you mean cataract out that has some visual symptoms associated with it.
Maybe even not, because if
Maybe
the
not.
literature is so strong that taking it out can lower IOP, not tremendously. I'm just thinking ahead. I mean, what would it take to get to the point where that would be accepted, either culturally, medically, or legally, to say that this is a standalone, actually a glaucoma procedure?
I don't think we need another indication for cataract surgery. I think visual disability related to whatever that level is for that individual is okay. Now, I do say to them that they might be on one drop. Just say they're on a prostaglandin. I usually take them off of that anyway. Taking this cataract out may allow us to follow you for some years without any drops. but the pressure will eventually, I don't think we talked about that too much, eventually come back. So over a period of some years, 3, 4, 5 years, pressure creeps up again and you wind up putting on a drop again. So, boy, I would hate to say that cataract surgery is an indication for glaucoma in the absence of visual disability.
Yeah, regarding the structural, I guess, modulation of the lamina in glaucoma, I was wondering if there's any evidence of the opposite, like with papilledema or pseudopapilledema.
I'm sorry, evidence that
it behaves the other way, like the structural modulation is reversible in a sense.
the role of the lamina in papilledema. Well, I'm sure there's a role for that because that's where the that's where the organelles build up, and that's where the intracellular organelles and mitochondria stop at the level of the lamina when there's a high intracranial pressure, for instance. So, yeah, the lamina is the cause of what we see as papilledema. Now, is the question, after the papilledema resolves, what happens to the lamina? I don't know. Not that I know of. No.
Dr. Chopra, you brought out SIPAS. So listen, we don't have a formal conversation about this today, but this is a glaucoma meeting. I think it's worth bringing up the recent changes with it being removed. I mean, what are your thoughts, and what can you talk to the room about? And no disclosures. Alcon's not here today, so it's okay.
So, I didn't have a chance because of the limit in time. I was going to show some slides on, why the SIPAS was withdrawn from the market and what we really should all be doing. There's actually, 2 committees that came together that looked at this question and how to address it. And essentially the conclusions are actually on the Alcon website, and I encourage anybody who is actually put in the SIPAS to, access that. It is imperative to inform the patients who have had it that there has been this issue. What they essentially found is that at the 2-year mark, there was no significant difference between the patients who had cataract surgery alone and cataract and SIPAS in terms of endothelial cell count. But at the 5-year mark, patients who in particular had a greater number of retention rings in the SIPAS. So SIPAS is this device that has 3 retention rings that you see in the anterior chamber. And the patients who had 3 retention rings on the SIPAS that were still visible had almost a 30% greater risk of endothelial cell loss compared to the controls. More than the 2 rings, more than 1 ring, and even the 1 ring has slightly greater risk than control. So it's really in the patients who have 2 or 3 rings that you do need to be concerned. So you should document what you see in gonioscopy, document that in the chart, and if the patient has a larger amount of retention rings visible, you can actually go in and trim the SIPAS. It's actually not that difficult to do. The difficulty in trimming it is that when you're putting it in, you have one hand in your left hand, if you're right-handed, like I'm right-handed, left hand on the gonio prism, and then the insertion, which is quite easy. But when you have to trim it, somebody has to hold the gonio lens, and then you have one hand that stabilizes the SIPAS and the other hand that cuts it. Now, if the stent is sticking out so much that you don't need the gonio prism, then you can actually visualize with the gonio prism, and then take the gonio prism off, and then just use both hands to cut it. Ike Ahmed, and it would be Ike, who's developing a new device now that is going to be able to hold the SIPAS and cut it at the same time, so that you can use the gonio prism to actually visualize it. I don't know what the timeline for that release is, but it's probably coming relatively soon. And then in terms of what to do follow-ups, now, the FDA has said that all patients should get specular microscopy, which was not the suggestion based on the AGS and the ACRS subcommittee that came together to discuss what to do, because not all of us have access to specular microscopy, and you don't have your previous specular microscopy on these patients. So you're looking for focal corneal edema, you're looking for patient's vision, you need to inform the patients what's happening, and really in the patients that have the extensive changes, the retention rings are 2 or 3, you do need to trim it most likely. Removing it is very, very difficult and likely not recommended. So you think, well, maybe you can just go pull it out. It almost always after a month, it's fibrosed in. You're going to get potentially a suprachoroidal hemorrhage. and you're gonna have a cleft there, even if you can get that thing out. So pulling it out is not a good idea, and pushing it in likely is not gonna work either. But you can try that first. So you can push it in. If you can push it further in, then that's fine. But if you can't push it in further, then trim it.
Is there any reason to believe that after cutting it, it's not just going to continue to function?
Yeah, so that's a great question. So the question is, so a lot of the intersegment studies that I published on, we're looking at essentially we've done them for future intracameral implants. There's bimatoprost sustained release that's coming out, travoprost sustained release that's going to come out, and all these things have to fit into the angle without touching corneal endothelium. So it's the amount of angle opening that's quite important. So even if the CyPass or whatever stent you're putting in the eye is closer to the endothelium, even if it's one retention ring, that may still be a problem.
Just one question.
Well, yeah. So we've talked a lot about tubes, and it's hard to believe that CyPass is going to be worse on the corneal endothelium than the presence of a tube. Now, it may be, but I don't know.
I think the issue that was raised, and I think you're absolutely right. We're putting in tubes all the time, but is it the patient population is different? These patients, maybe we've tried other things already, and this is sort of the next thing they need is a tube, and then you're willing to take that risk that, okay, there's going to be some endothelial cell compromise, but you're going to protect them from glaucoma, blindness. Whereas in CyPass, the indications from mild to moderate glaucoma, you're putting in often for, discontinuation of, say, latanoprost. Is that really worth the corneal risk? And it was only seen in that one study at 5 years. I mean, who knows what it is in the other stents.
Yeah, just one question. CyPass was approved by the FDA. What time period did they have before it was approved? If it was approved less than 5 years, is this a message for us to not accept any data that is less than 5 years, but it's got to be more than 5 years?
That's a great question, but in Europe, they had actually been using CyPass apparently for 5 to 7 years prior, but I don't think there was a formalized mechanism for looking at endothelial cell loss. So, that's a great question. Are we now going to require every device that comes out or every intracameral issue to have endothelial cell loss at 5 years? And are we then depriving our patients of devices if we have to wait 5 years at a minimum to have this?
Yeah, I agree with that. So, we don't know what happens with eye stents after 5 years. Nobody's done endothelial cell counts. Tubes, we know that tubes eventually kill corneas, although in the population, for instance, akin to the primary TVT study, these patients had moderate glaucoma. Somebody might put a CyPass in. We don't know what the endothelial cell counts are. So I think the moral of the story is don't do anything if they don't really have glaucoma that needs to be treated. If they're on one drop and they're doing fine and, one disc looks a little bit funny, I don't know if I would stick foreign bodies in their eyes for that.
The other thing is, specular microscopy has its own whole set of issues in terms of reading. We published about 2 or 3 papers on this at the Reading Center. It's looking at Gupta, you have to image exactly the same place, and it's often difficult to know sequentially. Are you really in that exact same area? And automated counts are really not reliable because the endothelial cells are in different sizes, and the default on the specular microscopy is quite different often than cell counts. So you have to use sort of a hybrid method. You have to look at the printout yourself, and you can change the default on the specular microscopy instrument and fit it accordingly. But the best way to really do it is there's a manual count you can do. So there's issues with specular microscopy as well.
So a couple of questions. I mean, even if you trim the CyPass, how do you know down the road it's not going to move again or probably migrate anteriorly? And two, we don't get baseline specular microscopies on these patients. So before and after, we don't know what the outcome is going to be.
So, the migration issue is probably less of an issue. Most of these patients, it probably was not implanted far enough in. It is, less likely, and I've done a very large number of CyPasses. For them to migrate out, I've almost never seen that. And we've done, ASOCTs on all of these patients, pre and post actually. So, that has not been my experience. I don't know if anybody else has seen that migrate, out. It's typically the difficulty of if there's a time in surgery, it's I have a hard time getting it in. It's a non-issue now, but hard time getting in. But this the Glaukos is going to introduce their suprachoroidal shunt, and we'll see what happens with that in terms of when that's going to be released. In that stent, the retention rings are on the distal end, the part that's going into the suprachoroidal space, not on the part that is exposed. The part that's exposed looks identical. Really, this titanium looks like the eye stent actually.
All right, so now it's time for the a break, and let's have something to drink, have some coffee, get some snacks. We're going to be back at 3:40, and make sure you stop by and talk with the vendors. And if you have any questions regarding any of the products or any of the things we've spoken about, thank you.